How you doing, class? Hope all is well, and welcome to week 1 of Pathology, PTA 1002. So today we're going to talk about Intro to Patho, stages of healing, and of course the immune system. So what's the objectives? Be able to understand what pathology means and the different ways that cells are injured. Compare reversible versus irreversible cell death. Understand the normal reactions to cell injury and the 3 stages of tissue healing. That's very important, so make sure you pay attention to that. Become more familiar with cells involved in tissue healing. Now again, everything is important, right? But I will point out certain things that hold a little bit more value over something else. Now, definitely want to know the definition of pathology, defined as the structural and functional changes in the body caused by disease or trauma. So the whole class is based on this pathology definition. Now, cell injury can lead to an inflammatory response which begins the process of tissue healing. Now that's something that's very interesting because a lot of times PTs use inflammation and swelling interchangeably. They're not the same thing. And actually, inflammation is actually good for you where swelling is not. So a lot of times people always want to say, hey, we should bring inflammation down, bring inflammation down. But acute inflammation is actually beneficial. It's long-term chronic inflammation that we don't want, and we'll talk about the difference there. Newer research has found that cellular aging has a profound effect on this pathology. Of course, the older you get, it's harder to fight off certain diseases. Certain conditions will get worse as we age. Additionally, there's a newer research regarding the effect of the nervous system on the immune and inflammatory responses, and we'll discuss that in detail. Now, this is very important again. So these are the 7 mechanisms of cell damage, and we'll go through each one individually, but you have ischemia, you have infectious agents like bacteria, viruses, immune reactions, genetic factors, nutritional factors, so nutrition plays a huge role, physical factors, and of course chemical factors. And I'll go over each and every single one, but pay attention to the broad category first. So a lot of times as students, what happens is we start to hone in on something very specific, but we forget to look at the big slide. Whenever you look at a slide, always like, okay, what am I talking about? I'm talking about cell injury. Then look at the subtitle. This is how cells can be damaged. Boom, 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 boom. Instead of just making flashcards and not really knowing what you're studying, take a step back and look at it. So let me give you a perfect example. Let's say a nice Lamborghini Aventador Alpine White pulls up, and then what you do is you focus on the itty bitty dashboard or the seats, and you don't even take into consideration that you have an Alpine White Lamborghini Aventador two-tone in front of you, right? So that's what I mean is like you're so worried about infectious agents, but you forgot to say, well, why am I even studying infectious agents? Right? So hopefully that makes sense, and hopefully when you look at this, you'll be able to study in a more efficient manner. So those are some tricks of the trade that will help you, and then I'll show you how to study efficiently as well throughout the semester and the program. So hopefully it helps. All right, so let's dive into the first part of cellular damage, and that's ischemia. The definition of ischemia, you should definitely know, is when blood flow is inefficient. So it results in the cell's inability to maintain homeostasis and metabolic function. Loss of blood flow reduces oxygen delivery to tissues and reduction in nutrient delivery and waste product removal. ATP synthesis reduces and ions and fluid increase in the cell. Okay, so now you're thinking about, okay, well, what's going on? When you read the book, that will definitely go into more detail, and I highly recommend you look at that and say, okay, let me read the part of ischemia and what else is going on here. Well, I've highlighted just the basics right here, because I'm not going to read you the pathology book, but these are some of the things, the take-home messages that you should look for when you're reading about ischemia. Now, infectious agents, obviously with coronavirus, we're always talking about viruses, but you should know the difference between a bacteria and a virus. Remember, bacteria does not need a host, whereas virus needs a host. How do you treat bacteria? Antibiotics. So if you have the common cold, there's no reason for you to take an antibiotic because the common cold is caused by a virus. right? So those are some of the things that you want to know. And then you have mycoplasms, fungi, protozoa. Those are some other infectious agents that we'll talk about. And all these agents release exotoxins. Each exotoxin has a different effect. Some cause cell death, some cause the spread of the infection. So we want to look at that. So when you're reading about this in the book, you want to pay attention to that. And again, on Friday, I'll pay attention and I'll kind of hone in on some of the specific things. I want you to be prepared when you come to class on Friday so you can ask questions. And if I don't know all the answers, well, I'll definitely help you look in the right places, but I should be able to answer most of your questions. Cell injury due to immune reactions. Now, the immune system normally defends against foreign agents, but they can become overreactive. This excessive activity can lead to mild allergies, life-threatening anaphylactic reactions, or autoimmune disorders. So when your immune system is hypersensitive, right? So that is what allergies are. Let's take pollen, for example. If you're allergic to pollen, cat hair, dust, those are actually not non-threatening, non-threatening, but your body thinks that it's threatening, so it mounts an allergic reaction to it. And that could be the runny nose, the watery eyes, the itchy eyes, and those are mild allergies. Sometimes you can have severe allergies, and that could be if some kids have peanut allergies or walnut allergies, they can go into anaphylactic shock. So everyone has a various stage. And then if they also have autoimmune disorders like lupus and fibromyalgia, and we'll talk about those a little bit later on, you definitely want to pay attention to that. Causes cell death via antibody attachment, complement activation, or activation of inflammatory cells. So that's how that occurs. And I do have some interesting videos that we can watch on Friday that will kind of hone in and help you reinforce this material. Okay. Now, you can have genetic alterations, right? Cause cell injury or death by changing the structure or number of chromosomes. Remember, we have 46 chromosomes, 23 from mama, 23 from papa. So there can be some genetic factors that can change the cells. Single mutation of genes. Now, not all mutations are bad, and some mutations occur and nothing comes out of it. But it's when a mutation occurs and changes the DNA structure that could be a problem. Multiple gene mutations that interact with environmental factors. Results vary from in utero death, congenital malformations, cognitive or developmental delays, and increased risk of leukemia and Alzheimer's, dementia. And I think it's week 2 or 3 that we'll talk about genetic disorders. So this is just an introduction, right? So hey, some genetic factors can cause some cell damage. Remember, we're still talking about cell damage, but you want to look at the big picture. Now, cell injury due to nutritional factors. Remember, nutrition is key. Imbalances in essential nutrients can cause cell death injury. Examples: deficiencies in amino acids that make up proteins can interfere with protein synthesis. Protein malnutrition is the greatest cause of death in impoverished countries and can occur in specific vitamins and minerals. Iron loss leads to anemia. Okay, so those are some things that we'll discuss a little bit more in detail on Friday. But again, I want you to read this chapter and be prepared. What about trauma? Yeah, you get hurt. Trauma and physical agents can cause cell death and injury. Blunt trauma can damage organs, cause brain contusions, loss of blood. Physical agents such as extreme temperatures, radiation, electricity can also cause cell injury. The physical stress theory proposes that changes in the level of physical stress can cause a predictable adaptive response in all biological tissues. So typical responses: decreased stress tolerance, you get atrophy. You have increased stress tolerance, you get hypertrophy, and then cell injury or death. So failure of a tissue occurs when the load exceeds the tolerance of the tissue. And that could be, let's take Kevin Durant for issue and his Achilles tendon rupture, right? Failure of a tissue occurs when the load exceeds the tolerance of the tissue. So obviously he put a load on it which caused that Achilles tendon to rupture. So load rate, the type, the compression, the shear, the torsion, the tissue properties affect the failure point. Okay, so can you name some more NBA players that have torn their Achilles, right? Kobe Bryant, Shaq, Charles Barkley, and just recently Klay Thompson, right? So Achilles tendon is very susceptible to injury and mechanical factors. What about cell injury due to chemical factors? Toxic substances can cause direct cell injury, or they may require metabolic transformation. You've heard of free radicals, right? Free radical formation constantly occurring can be positive or negative to the body, is addition or subtraction of one electron at a time in the cell. And the book goes into what free radicals are, but we've talked about these free radicals, antioxidants, right? Eating your fruits and vegetables, especially the berries, the blueberries, the raspberries, those are loaded with antioxidants, and they will help get rid of the free radicals. Nitric oxide is a free radical important to many functions: long-term memory, neural transmission, GI resistance to toxins. Reduced amounts leads to pathology, and one of the biggest things that nitric oxide does is, unfortunately, it causes impotence in men. So Viagra and Cialis is actually based on this nitric oxide. So, interesting stuff. Exercise and free radicals can have a positive or negative effects based on training intensity, load, frequency. Moderate levels protect against DNA damage, but excessive levels lead to DNA damage. So you don't need to be in the gym 8 hours a day and just doing bench press for 5 sets of 50. It's excessive. You're actually going to cause damage. But if you did 2 to 3 sets of 10, chest day, triceps, and then skip a day, and then in moderation, then you actually is beneficial. So there's always certain things that we want to keep in moderation. All right. All right, let's keep going. Talk about reversible versus irreversible cell injury. Now, so reversible stress is small in magnitude, short in duration, and cell can return to homeostasis with removal of the stress. So cell adapts in order to continue to function by changing in size, number, and function. Examples are atrophy, hypertrophy, hyperplasia. You work out, you put some stress, boom, you're going to get some bulk. I have the guns on safety right now, so don't worry, they're not going to bulge out right now. So irreversible stress is too large in duration or magnitude for the cell to adapt. So nucleus can be damaged, the mitochondria can lose their ability to synthesize ATP, and after cell death, lysosomes release digestive enzymes, leading to necrosis. That's not good. Okay. Now, what are some things, and this is a very important quiz question throughout your curriculum. So you definitely need to know the difference between a sign and a symptom. This will come up in the board exams, will come up in ortho, neuro, thorax. So really pay attention to this. And so symptoms are subjective. Okay, indications of disease reported by the patient, such as pain, dizziness, itching. Meaning, if you say you have pain, I can't really measure that in the sense except for you telling me. If you tell me you're dizzy, there's no like gauge or machine that says, yes, you have 40% dizziness that measures. It's just a subjective. Or if you're itchy, yeah, you're going to scratch, but there's no way to gauge that. Now, signs are objective. Evidence of disease observed by a physical exam, such as abnormal pulse, a respiratory rate, fever, sweating. I can see you sweat. Pallor, meaning you've lost color, right? So I can see those. Those are objective evidence. So make sure you know the difference between symptoms and signs and be able to give me an example of a symptom or a sign. Now, certain sets of signs and symptoms occur concurrently in some diseases, and that means that's a syndrome. Okay, so Down syndrome is a collection of signs and symptoms. Okay, so make sure you know the definition of symptom, make sure you know the definition of sign, and then definition of syndrome. Now, so here's a good little chart here: signs, objective, symptoms, subjective, and then they make a syndrome. Diagnosis of disease: the use of scientific or clinical methods to determine the nature of disease provides the basis for rationale and effective treatment of disease based on many factors. How do we do that? Diagnosis of disease: we can use laboratory tests, urinalysis, blood chemistry, ECGs, EKGs, radiography. Here's a funny thing about radiography, which I'll tell you, is x-rays. People use the word x-ray. Say, hey, did you bring your x-rays? But x-rays are actually invisible. X-rays produce an image on a radiograph or a film. So really, in healthcare, you should use, hey, did you bring your films or did you bring your radiographs? Is more educated. If you say, hey, did you bring your x-rays? You're like, unless you're a Superman, you really can't see. You don't have x-ray vision. But, just little things here and there, just to make you more educated. Diagnostic imaging techniques such as a CT scan, MRIs, ultrasound, nuclear medicine, all physicians to allow visualize structural and functional changes. Now, X-rays have some radiation, CT scans have a lot of radiation, MRIs have no radiation because they use a magnet. Okay, so you can get an MRI every day if you wanted to. There's no radiation risk. Biopsy is a surgical removal analysis of tissue samples. Then you do a physical exam, medical history, family history, and of course a medication history, because there's a lot of side effects of medication. So that's how you could do a diagnosis of a disease. Now, what's the course of a disease? So what's the prognosis? The predicted course and outcome of the disease. Does it have a good prognosis? Does COVID-19 have a good prognosis? Does HIV have a good prognosis? Okay. State the chances for complete recovery, predict the permanent loss of function, and probability of survival is all included in prognosis. Now, there are acute, chronic, and terminal course of a disease. Acute would be quick onset, short duration, influenza, measles, common cold, acute. Then you have chronic. A disease may begin insidiously and be long-lived, arthritis, hypertension, and terminal, a disease that will end in death, such as certain cancers, prostate cancer. Remission is where the signs and symptoms subside. Exacerbation means a reoccurrence in all severity. Relapse returns weeks or months later after apparent cessation. Okay. Now, what's the outcome of a disease? You can have complications, diseases, kidney failure secondary to diabetes. You can have sequela, which means the aftermath of a disease, paralysis following polio. So polio caused the sequela of paralysis. Mortality is the measure of death attributed to disease, and morbidity is the measure of disability. So remember, make sure you know the difference between morbidity and mortality. So in COVID-19, comorbidities are leading to mortalities, increase in mortality, right? So the more comorbidities you have, disabilities, the higher risk of mortality rates. So risk factors predispose an individual to the development of a disease. Risk factor is not equivalent to a cause. Could be environmental, chemical, physiological, psychological, or genetic. All right. Hello class, welcome back. So now we're on tissue healing. Now, tissue healing, of course, begins soon after injury, actually immediately after injury. So it occurs by regeneration, which is regrowth of original tissue, repair, which is formation of connective scar tissue. And how does it work? Initiated by blood circulation breaking down and removing necrotic tissue. Phagocytes secrete degradative enzymes that envelop and destroy cellular debris, connective tissue fragments, plasma proteins in the dead cells. So that's very important for that to occur. Now, fibronectin, which is a component of tissue healing, it forms this scaffolding, right? Provision of tensile strength, glues substance cells together. That's like when that fibronectin is coming together and then you tear it again, it's where it's in the next day or so if you go to bend your finger a little too much or bend your wrist back. This is that protective stage that you have to be careful, and you don't want to make a lot of aggressive range of motion during this time. Earliest protein to provide structural support to stabilize the healing tissue. Now you have proteoglycans and elastin. Proteins contain carbohydrate chains and sugars, bind to fibronectin and collagen to help stabilize and assist in repair. Proteoglycans retain water and aid in the hydration of tissues. Proteoglycans then assist in the organization and stability of collagen. and fibroblast synthesis and secrete elastin, a protein that becomes cross-linked long sheets of tissue that provide elasticity. You're thinking, whoa, Patel, that sounds very complicated. Yes, it is a little complicated. If you actually read it in the book, it'll actually go through the stages. But one of the things that you want to realize, and one of that kind of like the take-home messages, as we get older, it takes a little bit longer to heal, but we form less scar tissue because the body is taking time to lay down the elastin and the collagen. Now, you remember as a child, you're probably like, you can look at on your fingers or on your arm, you're like, oh yeah, I remember that scar jumping the fence when the cops were chasing me. Yeah, I don't know. Maybe cops were chasing you, something. But you can really look back and say, okay, yeah, I remember that scar from chemistry class. When you're younger, think about it. Your body's like, oh, I just need to get that, boom, 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 and it doesn't really lay the collagen down in nice little layers. It just lays it down like crazy, and then it repairs it real fast. But then you have a gnarly scar. Okay, so the younger we are, we heal faster, but we scar worse. The older we are, okay, it takes longer to heal, but we scar less. Okay. Now, scarring does have other factors, and when we talk about skin, we'll talk about that, because obviously if you have darker skin, then it's going to take you, you might keloid a little bit, and you might have more scar tissue. The lighter skin you have, the less scar tissue you have. So skin pigmentation does play a role into scar tissue as well. Collagen. Collagen provides structural support and tensile strength for almost all tissues and organs. The word collagen means glue producer. Fibrous protein molecule consisting of 3 chains of amino acid coiled around one another in a triple helix. At least 27 different proteins have been identified, and each collagen has a very specific function. Collagen organization, unidirectionally or in parallel bundles, contributes to the strength of tendons. Arranged in random arrangement provides flexibility of skill and rigidity of bone. At right angles allows transmission of light into the cornea. Laid down in tubular fashion contributes to the elasticity of the blood vessel. So collagen is found all over the place. Okay. Types of collagen, and so this is something that you probably want to get familiar with. So you have type 1, which is the most common, thick bundle, very strong, main component of mature scars, and is predominant in strong tissues such as tendons and bones. So type 2 is predominant in cartilage. Type 3 are thin filaments, makes tissue strong but supple and elastic. First type deposited in wounds. So here's the collagen structure again. I won't have any diagrams on the quizzes, so you don't have to worry about memorizing like slides or anything like that, but you should know the different types of collagen. Now, factors that affect tissue healing. There's a lot of things that can affect tissue healing. Growth factors, regular cell proliferation, differentiation, biosynthesis assist in reparative process. Nutrition, how healthy you eat. Injury increases rate of protein loss. Zinc assists in protein synthesis. So having a good diet, fruits, vegetables, protein, vitamins. Comorbidities, smoking history, immunosuppress, CHF. Vascular supply, presence of another infection, immune reaction, age, and medications all play a role in healing. So if you look at this diagram right here, it seems a little overwhelming, but it really isn't. So contributing factors and components of inflammation. Okay, so factors leading to inflammation: lack of adequate blood flow, damaged tissue, cancer, infectious biological organism, foreign material, chemicals, physical agents, heat, cold, radiation. So these factors leading to inflammation. Okay, so production of inflammatory mediators. So this is what causes inflammation. Production of inflammatory mediators. Now you're thinking physical agents, cold, and you're thinking cold usually decreases inflammation, right? So we'll discuss in class about icing and inflammation, because a lot of times we ice longer than we should, because remember, we want a little bit of an inflammatory response, and if we ice it, we actually stop the inflammatory response. Now if we ice it too long, we can increase that. So there's a big factor, and we want to discuss that as well. Production of inflammatory mediators, factors attracting and stimulating cells, C5, lipooxygenase products, lymphokines, monokines. In the acute inflammation, cellular infiltrate, you'll find platelets, neutrophils, monocytes, fibrocytes, endothelial cells. In chronic inflammation, you'll find monocytes, lymphocytes, plasma cells, fibrocytes, and endothelial cells. Okay. Now, factors affecting blood flow, and you get histamine. That's why you get the histamine response. You get that flushing red, serotonin, bradykinins, anaphylactoxins, leukotrienes, prostaglandins, and then you get vasodilation, which is increased vascular permeability, and therefore you get edema. So again, this just kind of takes you like a little algorithm of the inflammatory process and what leads to what. In the book, once you read that, it'll kind of guide you in a more systematic way. This is just, I'm just pointing this out so that you can take a look at in the book as well. Remember, the PowerPoints serve to point you in the right direction, but the book is what really will put it all together. So you do have to take the time to read that book. Chronic injury cycle. All right, so we're back to where, if you look at this chronic injury cycle, and this is pretty much your patients. Okay, so let's say they have an injury, or the case may be a rotator cuff injury, ACL, knee injury, where the case may be. First of all, they're going to get acute inflammation. Now, acute inflammation can go two directions. First of all, it can go injurious agent is removed, right? That's at the cellular level. The labile or stable cells are little necrosis, and then boom, normal function. So ideally, that's what we want. A little bit of inflammation, get rid of all the bad stuff, little necrosis, and then boom, back to normal function. That's an ideal world, right? What's going to happen is, well, you get an acute inflammation, but you continue to have repeated episodes of acute inflammation. Well, that can lead to chronic inflammation. Okay, or the injurious agent persists, meaning due to comorbidities or due to chronic injuries, you just can't get rid of that injurious agent. Okay, so that leads to chronic inflammation. What about if the injurious agent can't be removed and you have permanent cells or extensive necrosis? Well, then you can get scarring down. Okay, but once chronic inflammation develops, you get common morphological features of granulation tissue, macrophages, lymphocytes, and plasma cells. Then you get organization, it disrupts organization, then you get scarring, and you get persistent abnormal structure. So this is a great little diagram that shows what your patients will go through, whether it's rotator cuff injury, low back pain, knee pain, Achilles tendonitis. So I'll tell a lot of times, think about tendonitis. Itis is acute inflammation, but then usually by the time that the PT sees them, it becomes osis, which is chronic inflammation. So in order to get rid of some of that chronic inflammation, if you have common morphological features, and you have scarring down, that's why we do soft tissue, deep friction, the Graston technique, ultrasound, all that to basically go from the chronic inflammation phase maybe back to the acute inflammation phase and tell that body to say, hey, we need to recover. Okay, so those are some of the things, the beneficial of massage, cross friction massage, ultrasound. Some of those, we're trying to break that cycle of chronic inflammation and maybe jumpstart it back into acute inflammation and then tell the body to heal again. So very important aspect there. All right, stages of healing. Let's break that down to another video here. So now, why is all this important, right? Learning the stages of healing, etc., etc. Well, stages of tissue healing all come back to us as rehab professionals. So one of the first things as a PT must do prior to treatment is to determine the stage of healing of the affected area. Is it acute? Is it subacute? Or is it chronic? So identifying the healing stage will help with choosing appropriate treatment activities and techniques, eliminating harmful activities and techniques, and increasing the odds of a successful outcome. Make sure you star this slide. Make sure you know why we learn the stages of tissue healing. That's a great quiz question, and you should know this. Okay. Again, I'm not going to emphasize, hey, that you should know this or this because, but this is something that I definitely think that it's vital for clinical experience. So it is very important. Now, all connective tissues go through similar vascular and cellular responses to injury of any kind. They're divided into 3 overlapping stages. Now, so here's the key: overlapping stages. So there's not all of a sudden you're like, okay, you should be out of acute and then you should be immediately into subacute. They overlap, and in some patients it varies a little bit, but you kind of have a general guideline. So the 3 stages are acute, subacute, and chronic. In the acute phase, we have reaction and inflammation. In the subacute phase, you have proliferation, repair, and healing. In the chronic stage, you have maturation and remodeling. So if a tissue is repairing as it should, it will progress through each of these stages. If the tissue does not repair along this continuum as expected, it will result in chronic pain syndrome. All right, let's take a look here. All right, so this is a good little graph that shows acute can last from 0 to 4 to 6 days. Again, it overlaps a little bit. Subacute can be from 6 to 21 days, so 1 to 3 weeks. Tendonitis subacute could be 6 weeks. Chronic can be from 3 weeks to a year. Okay, so it really depends on the tissue, but that's your general guideline. So this is something that you should know. Again, acute, subacute, chronic. So if you were to put on an exam or on a quiz that acute is from 0 to 4 to 6 days, subacute is from 4 to 6 to 21 days, so and then 6 weeks is tendonitis. Chronic is 14-21 days to 6 to 12 months, and that would be correct. Okay, so use this little thing, and then also you can read inside the book, and it gives you a little breakdown of the stages and what occurs during that time. And of course, we're going to go on to that. So again, inflammation, acute inflammation is 4 to 6 days. Then you have proliferation that takes anywhere from 4 to 24 days, and then you have remodeling, which is 21 days, sometimes 2 years. Okay, so here's the other thing is, okay, you have a little bit of inflammation. So think about this. You have a little bit of inflammation, and in order to go on to the next one, we need that inflammation. And that allows us to go into the proliferation stage. But think about this. If in the 4 to 6 days, we just keep, we can ice it a little bit, but imagine if we just keep icing, and now you're delaying the inflammatory response, right? Because icing does delay the inflammatory response. Then we never get into the proliferation stage, and we never get to the remodeling stage. Okay, so too much icing, and that's where you have to be careful. Too much icing can delay the healing process. A little bit of icing is fine. So what I usually recommend for my patients is ice for pain only. So ice does a good job for pain, but you don't want to say go ahead and ice for your swelling or ice for your inflammation, because that's not really true vocabulary. And swelling is tied to the lymphatic system, which we'll discuss later. So swelling is not going to go away from icing. It actually goes away from movement, muscular contractions, because that's how the lymphatic system drains. Okay, so those are some things. Knowledge is important, and this is why you take a class, and this is why you can give facts and true facts versus what they read on WebMD or Dr. Google, right? All right, so now take a look at this. Days after wound healing. Now this is, here's the inflammatory response here, and here's the proliferation, and then here's the matrix remodeling. Okay, so this is about 300 days or so, so that's basically a year. So initially, yes, you have bleeding, coagulation, platelet activation, complement activation. So yes, we want to stop that bleeding, okay, coagulation. You have granulites and phagocytosis. And then during the proliferation stage, you're going to get fibroplasia, angiogenesis, re-epithelialization, extracellular matrix, collagens, fibronectin, proteoglycans, which we discussed earlier. And then you also have macrophages and cytokines in the first few days here. Okay, so this is all very important. Then the remodeling stage is that 21 days to a year, sometimes 2 years if you're diabetic or you have other health issues. Okay, and that causes extracellular matrix synthesis, degradation, remodeling, tensile strengths, decreased cellularity, and decreased vascularity, but we want increased strength here. Okay, so again, the book does a good job of going through this, but this is, in a nutshell, this is the stages of tissue healing. So let's go reinforce this material because this is something that's very important. So acute stage of tissue healing, that's the first stage. The first 4 to 6 days, unless re-injured, right? So if you don't rest it, and if you keep re-injury, if you go out and let's say you sprain your ankle, and if you don't rest it the 4 to 6 days and you go back and play again, you re-injure it, well, then you start all over again. Tendons, inflammatory phase can be 1 to 7 days. This includes homeostasis and degeneration and inflammatory process. Clinical signs of acute stages of tissue healing is swelling, redness, heat, loss of function, and pain at rest. So these are the clinical signs that you'll see that a patient has acute injury. Okay, swelling, redness, heat, loss of function, and pain at rest. Now, what's homeostasis and degeneration? Body tries to stop bleeding by initiating coagulation by clumping platelets to form a loose clot. So hemostasis is cessation of bleeding. Okay. Now I think I made so this should be hemostasis. Okay. Homeostasis is what your body goes through, which is just keeping everything in balance. Platelets release growth factors that bring inflammatory cells to the area. This stimulates proliferation and migration of epithelial cells, fibroblasts, vascular, and endothelial cells. Alright, so now we go to the inflammation. The inflammatory cells bring fluid to dilute harmful substance in infection-fighting cells, macrophages and neutrophils. This phase is protective and curative, begins once blood clot is formed. Vasodilation occurs with increased capillary permeability to move important cells. So we want inflammation. Inflammation is good. You have polymorphonuclear leukocytes and macrophages. They destroy bacteria. They release proteases, elastase, and collagenase. You get growth factors, cytokines, and chemokines. Bioregulators of the process. Overlapping function brings in cells that create granulation tissue. Now, what happens is bacteria binds to receptors on the leukocyte. Engulfment of the bacteria and oxygen bursts to kill the bacteria. Bacteria is encased in a phagocytic vacuole to accomplish the final degradation of the bacteria. Okay, boom, boom, boom. That's if there's bacteria involved. Now, actions of cytokines, interleukin-1 and TNF, which is the tumor necrosis factor. What happens at the local level? Well, you stimulate leukocyte adhesion to endotheliums. You modulate the coagulation cascade. You stimulate production and or secretion of inflammatory mediators. Activate fibroblasts, chondrocytes, and osteoclasts. That's what happens there. Now, systemically, you might have induce a fever, increased body metabolism, decreased appetite, induced sleep, induce adrenocorticotropic hormone release to secrete corticosteroids, nonspecific resistance to infection. Hemodynamic, you might cause hypotension, decrease in blood pressure, cause hypovolemia, which sepsis. Hematologic, cause changes in blood chemistry, activate endothelial macrophage and resting T cells, increase neutrophils in circulation, decrease lymphocytes, and stimulate synthesis of collagens and collagenase. Okay, so this is what can happen at the local level, and this is what happens at the systemic level. Now, do you need to memorize every single thing that's on this chart? No, but you do need to have a general idea of what's happening at the local and the systemic level. Now we go into the subacute phase. Actually, we can stop here and go to the next video. go into the subacute stage, and subacute stage is 14 to 21 days after injury. Certain tendons repair phase, it could be about 6 weeks. Okay, this includes the proliferation and migration phases. But the key is the clinical sign of a subacute patient will be pain with end of motion at a joint or tissue. Remember, in the acute phase, they have pain even before you get to end range, or they might have spasms. Subacute is that pain is synchronous with pain at end range, and the muscles may test weak. In the acute phase, we don't even do muscle testing because they might be in so much pain there. So, proliferation, migration within 2 days after skin wound or injury, endothelial cells from blood vessels near the necrotic tissue. This creates a way to transport oxygen and nutrients to support the healing tissue. Now, the chronic stage of tissue healing, maturation and remodeling, lasts from 6 months to a year. Tendons remodeling maturation phase, 6 weeks to a year. Okay. Clinical signs. Now, how do you know someone is in the acute stage, subacute stage, or the chronic stage? So, in the chronic stage, they may have restrictions in tissue. That should be tissue. Pain usually occurs after tissue resistance due to stretch. Okay, so really end range, maybe at stretch. May have muscle weakness, poor endurance, and poor neuromuscular control. So what we really have to do is all the information that we've taken, right, from acute stage, stages of healing, and the chronic stage, and then we look at injuries, and in class we'll talk about this. But what you want to do is you want to think about muscles, tendons, ligaments, and discs. Right? So I mean, those are kind of the injuries that we will see: muscles, tendons, ligaments, and disc. And realizing what stage of healing they're in, and did they have surgery, no surgery. That way we can know what we want to do in the clinic. So let me give you an example. So if somebody had a tendon repair, Achilles tendon repair. Let's take Kevin Durant, for example. Right? And he just had surgery. He's in the acute phase. Well, you understand when you go back to the acute phase of healing, right? There's clinical signs: swelling, redness, heat, loss of function. You're not going to have aggressive range of motion. Right? You're not going to be like, oh yeah, Kevin Durant, man, I'm going to push the heck out of his range of motion and get him back to playing in no time. No. It doesn't matter if you're Kevin Durant, Kobe Bryant, or just some Joe Schmo off the thing. The normal healing process of a human takes this designated amount of time. So what you have to do now, with comorbidities, the time frame may be more or less, but it's better to follow these timelines and realize that you can't push the patient past the stage of healing that is occurring. And this is the biggest mistake that I think PTs make, is that they try to do more because their patient is doing better than they think, and they think, oh, they're way ahead of schedule, but you can't see microscopically inside the patient. So, and I will give you some guidelines in class of when to do passive range of motion, active range of motion, etc., etc. But these are some of the things that you really want to understand tissue healing in order for you to make sure that you don't make mistakes when it comes to rehab or doing more aggressive exercise than the tissue should go. And like I said, that is what's going to cause problems in the clinic, is when you try to do more than you should. So another example would be doing band exercises before 8 weeks in a tendon repair. Well, first of all, the tendon is not ready to withstand that resistance. So if you start to do band exercises before 8 weeks in Achilles tendon repair, you will damage it due to the tissue healing process. So it'll all come together, and in class we'll go over this more in depth, but pay attention to it. There is a nice little thing in the book that you can read about, but we'll discuss it in breakout rooms and with each other as well. All right, so that was good. Good job.